Hi, my name is Christine Delisle. I'm an FNP student at United States University. I am currently attending clinical at Family Medical Associates in Seekonk, Massachusetts. It is a primary care practice seeing patients of all ages. My case study is unique because it's something that I have a little experience with. I generally see people with this diagnosis later on in their course of disease at the hospital, and usually during an exacerbation. I have never seen a patient diagnosed with this from diagnoses. I have a family friend who also has this particular diagnosis and was really surprised at how similar her case was to my case study. So my patient NO is a 32-year-old Caucasian female who presents to the medical office with a complaint of fatigue and tripping over things. This fatigue and change in coordination started 3 weeks ago. She was concerned that she might have a vitamin deficiency, so she started a B complex vitamin and a vitamin D. She had no relief from these two medications, no change in the fatigue or in the coordination. Nothing seems to have made it worse. She's had no change in either of her symptoms. Now, this is a relatively healthy 32-year-old female. She has no past medical history. She has no history of smoking, drinking alcohol, or taking any illicit drugs. She is very active. She exercises in some form every day, hikes on the weekends, takes bicycle trips, eats a healthy diet. She's an accountant who works from home. So there isn't a lot of exposure to different things. Her physical exam was benign. Her vital signs were benign, all within normal limits. She has a family history. Her mom has some hypertension. Dad is completely healthy. She has a brother with some hypertension and some diabetes, as well as some obesity. Her sister has no past medical history. She has a remote past medical history with a couple of grandparents of pancreatic cancer and some Alzheimer's. But she's had no symptoms of anything other than the fatigue and the coordination. My differential diagnoses included anemia, and the reason for this diagnosis is the patient has stated that her menstrual periods can be a little bit on the heavier side at times, and so anemia can present with some fatigue. So it's one of the diagnoses we're going to rule out. Second diagnosis is Epstein-Barr virus. It presents with fatigue, fever, general malaise, poor appetite. The patient has had no exposure to any viruses and isn't complaining of any other symptoms other than the fatigue and coordination problem. My third differential diagnosis is fibromyalgia. This can present as unspecified pain and extreme fatigue. It also can be present when there are vitamin deficiencies, which the patient has been supplementing and eats a healthy diet, so that shouldn't be her main diagnoses. The main diagnoses that we are ruling in would be multiple sclerosis. Now, multiple sclerosis initially presents in females predominantly between the ages of 30 and 40. On initial presentation, it presents with fatigue, coordination changes, and visual changes. The patient denies any visual changes. Diagnostics that I would like to have performed would include a CBC and a BMP to rule out any anemias, any viruses, any electrolyte abnormalities. Also would like to do thyroid labs to rule out any hypothyroid or hyperthyroid. The gold standard test for ruling out multiple sclerosis is an MRI. It's a non-invasive test that can show whether or not the patient has multiple sclerosis. Gene Watson's caring theory is the primary treatment of the patient involves the patient. Human beings cannot be healed as an object. We spent a lot of time with our patient. This is a very scary potential diagnosis. Going over the treatment plan, explaining to her why we thought that this might be a possibility. My preceptor has a lot of experience with this diagnosis in this setting. One of the main treatments, if the patient has definitely multiple sclerosis, would be a neurology consult, maintaining a healthy diet, maintaining an exercise program. She would need to be educated on sticking to her treatment plan, taking her medications properly. The primary treatment for MS is to start on a disease-modifying therapy such as Ocrevus. This has been demonstrated to have efficacy in treating both relapsing and primary multiple sclerosis. Corticosteroids are also still the treatment of choice for patients with acute significant symptoms. There are no blood tests noted to diagnose MS specifically. In some cases, acupuncture and physical therapy can be known to help with the symptoms of MS.